So I'm going to spend a few minutes talking about mechanical circulatory support in destination therapy. We have two patients in our institution that really illustrate where we have come with these devices. We had one patient a few years ago who had an older pulsatile pump in for his destination device, and he would complain of getting near syncope and feeling poorly when he would play golf. And so when he would swing, his device would kink. So he would get a little faint because he didn't have cardiac output, and so that sort of limited his life performance with that type of device. Most recently, we had a young man who was bridged to transplant with the newer continuous flow device, and he was able to work as a custom motorcycle builder in a machine shop with this LVAD. And you can imagine the kind of work that he did with heavy machinery and building big motorcycles. And so that's where we've come with these new generation devices. So I'm going to cover that today. I'm going to overview our currently available devices and approval status, both for bridge to transplant as well as focusing on destination therapy, compare a little bit the outcomes we have currently, and then talk about patient selection, risk stratification, and ultimately, since these patients are on destination therapy, what that final destination, which is unfortunately death, and how we deal with that with our new devices that are much more durable and effective. The INTERMACS, Interagency Registry for Mechanically Assisted Circulatory Support, is an ongoing database for patients that have mechanical circulatory support, and there's a way to stratify those patients according to 7 classes into their need for device intervention, if at all. The most important one is the Class 1. So the Class 1 classification is the sickest patient. They're in critical cardiogenic shock and need immediate mechanical circulatory support. As you progress down that scale to the patients that get near 6 and 7, some of those may not need mechanical intervention at all. The current, we have several devices out on the market now, depending on where you work in the world. They're listed here on the left side with representative pictures. The Reliant Heart Assist 5 device is CE mark approved for both bridge to transplant destination in Europe. It's currently in trials in the U.S. The Thoratec HeartMate 2 is CE mark and FDA approved for both indications, and that's this device here on the right side. The Jarvik 2000 is CE mark approved for both indications, is ongoing trials in the United States with the FDA. The Heartware HVAD is CE mark and FDA approved for bridge to transplant and is ongoing DT trials in the U.S. The DuraHeart is CE mark approved for both and ongoing FDA trials, and then it's almost like we get one device going, it's in trial, and the next one is waiting to come on the market. And so now we have the HeartMate 3 here on the left side and the Heartware MVAD, extremely tiny devices building on the predecessors. Now let's move to implant strategies. So this talks about how we decide to put a device into a patient. The multi-center report from 2013 reviewed the INTERMACS database for the effect on implant strategy and eventual outcomes. So 3 basic implant strategies. It's bridge to transplant, so the patient's a candidate for eventual transplant. There's destination therapy where they're not. And then in the middle, which is called bridge to candidacy. And the concept is that putting the device in the patient, they may improve enough to eventually be listed for transplant. These are all continuous flow VADs over a 5-year period. 2-year survival, as you would expect, is better for the bridge to transplant patients. They're healthier, they are a candidate, and eventually get an organ. At 1 year, transplant is most likely and death is least likely in that bridge to transplant group. Importantly, what the investigators found is that about a quarter of the patients that were assigned initially to destination therapy eventually approved enough to become eligible for transplant, which is a new and unexpected clinical scenario. So here's the stratification. Bridge to transplant patients, again, expected most would get a transplant, but the destination therapy, look how many are alive at 24 months, doing well on their device, and some actually become candidates for transplant. So these continuous devices have improved that. The multi-center experience by Kirkland and Associates also looked at the INTERMACS database, reviewing of the destination experience alone, looking at pulsatile versus continuous flow pumps. Risk factors for mortality were identified, the most important ones being older age, that INTERMACS level 1, so the critical cardiogenic shock, and then the use of a pulsatile device. And what this has really highlighted is how we've moved rapidly away from pulsatile devices now to the continuous flow machinery. And major adverse events are all lower with continuous flow pumps. Survival at 2 years, about 60%. And subgroup analysis actually identified patients with a continuous flow VAD who were not in cardiogenic shock and had normal kidney function had equivalent survival at 2 years to a transplant population. And that is a remarkable advance in these machines. So again, here these patients down here are those level 1 intermax, very critically ill patients. They don't do as well over long term. But any of the higher intermax levels do quite well with the continuous flow LVAD. The Duke Single Center experience was published in 2010 using extended criteria alternate list transplant. So that's patients that have either significant comorbidities or it's an organ that is not optimal to try to expand the donor organ pool compared to destination therapy. This is a long-term series out to 8 years. Higher percentage of the patients with destination therapy were on support prior to their index operation, so sicker patients, and then propensity matching. But they found the 1 year survival was similar, better survival in that extended criteria group at 3 years, 73% versus 50%. But when they matched the pairs, there's actually similar survival. And particularly when you take out those older pulsatile pumps and looked only at the continuous flow VADs, the survival was equivalent. So here's that survival looking at those pulsatile pumps compared to the transplant extended criteria patients. So good midterm results with those. Now, when we talk about patients for destination therapy, we try to identify those that are at high risk, so we make sure we're using appropriate resources. And the multi-center group in 2012 attempted to use what's known as the destination therapy risk score to try to stratify these patients. And this was a score identified and used for the pulsatile devices, so they applied it to the new continuous flow devices, calculated in over 1,000 HeartMate 2 patients, and then analyzed them according to why the device was placed and then their various risk stratification. 90-day mortality obviously went up according to level of risk, so the high-risk patients with the poorer survival. Unfortunately, this risk score didn't give us a lot of information about the continuous flow devices, so we don't have a real good statistical model to use for these patients. It had poor correlation for bridge to transplant and only modest correlation for the destination therapy. So again, using that risk stratification model, you get out to 2 years, the survival is all about the same, and the risk stratification didn't help that much. But two risk factors that do help us understand use of these devices are frailty and age. So the combined Mayo Cleveland Clinic experience analyzed the impact of frailty on destination therapies, about 100 of them. It's a deficit index of about 30 various categories. And they found that the intermediately frail or very frail patients had a significantly increased risk of death. And if you're frail, the hazard ratio is about 3 times in a non-frail patient. So that's pretty obvious here from this graph. The more frail the patients are, the higher the risk in mortality. Moving to the elderly patients, the Penn group reviewed the Intermax database, comparing elderly to non-elderly continuous flow destination therapy patients. Nearly 600 patients that were considered elderly, age 70 or older. These patients were actually likely to be more hemodynamically stable prior to their implant. A little bit higher stroke and GI bleeding risk in the elderly patients, lower driveline infections, and a little bit lower survival in the elderly patients. But importantly, even though the survival is lower, it's still a reasonable option in this elderly cohort. So again, as we get out to about 2 years here, not too many out farther, but 2 years, a little lower survival in the elderly population, but still quite good compared to the non-elderly. And then a single center review from San Diego, a smaller series, continuous flow, elderly versus non-elderly, no survival difference at 2 years, no difference in hospital stay or adverse events, and both patient populations had improvement in quality of life and functional status. So again, older patients at higher risk, but still destination therapy now provides them good quality of life and appropriate outcomes. These devices are expensive and are a significant burden on our healthcare system as we consider implanting more of them. A multi-center trial, multi-center evaluation analyzed costs, which is a difficult thing to do. compared to medical therapy using the outcomes from the REMATCH trial and the more recent HeartMate 2 destination therapy trial. Attempted to analyze billing data, costs, rehospitalization, and outpatient costs, and then forecast that over expected 5-year survival. And what they found is that the patients that got devices had greater quality of life gain compared to medical therapy. Obviously, there was a higher cost for putting in the LVAD with that device technique and all that goes into that, but the cost effectiveness when they looked at the continuous flow devices was markedly improved compared to the pulsatile devices. So about $200,000 per quality adjusted life year compared to nearly $800,000 with a pulsatile device. And so this graph's a little bit complicated, but what's important to see here is that if you have optimal medical therapy, well, it doesn't cost very much, but you don't improve their life very much. And as you move up, the patients that get sicker and sicker, there's a larger benefit for putting in an LVAD, even though it costs more. These newer devices are more durable. So the INTERMACS database review for device-related failures compared pulsatile devices to the continuous flow pumps, and a device failure is classified either as a death due to the device or that the device has to be removed, and that's usually infection, hemolysis, or thrombosis, or there's a failure either of the driveline or the pump unit. Comparing pulsatile and continuous pumps, the continuous flow devices are much more durable, improved freedom from failure of the actual device itself and less infection, similar outcomes for hemolysis and thrombosis, and the survival in a continuous flow VAD is double that of a pulsatile device. So this is pretty obvious here. As those pulsatile devices start to wear out, and we saw this in our institution, they begin to fail. Those continuous devices are extremely durable, and now we are looking at patients with extended survival in destination therapy. Part of that decision-making then becomes, when do you turn the device off? So this is sort of the ultimate turning a patient off and allowing them to die, because the devices now will occasionally and maybe often exceed the patient's own lifespan. So at our institution, we reviewed our database of patients on destination therapy and tried to identify those that had participated in their own decision to end their life, and looked at the causes that prompted that and how long it took them to die and where they died. So we had about 20 patients that elected to participate in their own end-of-life decision to turn their machine off and pass on. Most of these were prompted by a decline in their quality of life, sometimes due to device complications, but often due to other problems, such as cancer or advanced age. The time to withdrawal was actually quite rapid. The patients would come to the decision quite quickly and say, I'm ready to do this, and within a day or a few weeks, they would make that decision. The time to death is rapid. So disconnection of the device and turning it on leads to death rapidly, within 20 minutes in all the patients, and many of them elected to do this at home. So these are important decisions that need to be addressed as we have more durable devices and more patients that receive these devices. And then finally, just a small comment about partial LVAD use. Most of our devices are intended for complete replacement, so generating flows of 5 to 6 liters per minute, so that the heart itself has no real addition to the device's effect. A small study out of Belgium and Germany using the Circulite Synergy system. This is a very small device intended only to flow about 3 liters to 3.5 liters per minute. It's implanted with a right thoracotomy. Inflow comes from the left atrium and then outflow into the right subclavian artery, so it's over on the right side of the chest. Flows, again, are only up to 3 liters per minute, and it's partial support. They were using it for bridge to transplant, but analyzed it as possibly a potential for destination therapy. And what that device can do is generate partial flows in improved cardiac index, reduced wedge pressures, and reduced pulmonary vascular resistance with low adverse events. So this is another potential option as these devices get smaller and more advanced. Maybe patients don't need full replacement, but only partial support to improve their quality of life with destination therapy. So the question is, how far can we go with these devices? We don't have that answer yet. There clearly is advancement in this field. We clearly are getting better about our patient selection and management. This graph shows the optimal medical management arm of REMATCH, the improvement we made with pulsatile devices in the REMATCH trial, now the improvement that's been made with the continuous flow HeartMate 2 destination device, our experience in Utah with our HeartMate 2 continuous flow devices, now the HeartWare HVAD, and that's approaching the outcomes of transplant at 2 years. Our transplant curve obviously goes a little bit farther than our devices, but I think we really have an unlimited future ahead of us. So in conclusion, our ongoing destination therapy trials will hopefully allow more device availability for this patient population. We don't have enough organs to go around, so we need these devices. These continuous flow devices are markedly improved durability, better performance, and cost effectiveness. We do need to learn to risk stratify who will be appropriate patients to receive these devices. And as all of them eventually will face death, we need to involve our patients and be cognizant of those decisions that need to be made at the very end when the device needs to be removed. In conclusion, I'd just like to make a remark from my mentor, Dr. Duke Cameron at Johns Hopkins. He used to say about these kind of devices that we're very good at taking care of humans and we're very good at building machines, but it's the human-machine interface that we still haven't figured out, and this is going to help us learn that. Thank you.